Yeah, it's not really clearly, but it's okay. Make sure that you are very close to the mic.
Okay, sir.
If your examiner can't hear you, he can't give you marks.
Okay, sir. Sorry, sir.
Can I start video?
Yes, please.
Good evening, everybody. Welcome to our next episode of the APOS ARC Short Cases webinar. And we are very happy to have with us today Dr. Ravi Kiran Potluri. He is a senior consultant at Shankar Netha Chikitsalaya of Eluru, as he is one of our examiners. And also uh, we have Dr. Rajendra Prasad. He is the professor and HOD of Department of Ophthalmology at Pinnamaneni Siddhartha Institute of Medical Sciences and Research Foundation at Gannavaram. That's also near Vijayawada. The two distinguished examiners we have today. Today's presenters are going to be Dr. Akanksha. She is a second year DNB resident from SV Arvind Eye Hospital at Tirupati. And we have Dr. Akanksha will be presenting a case of pterygium, which is definitely very useful for the postgraduates. And we have Dr. Srinavya. She is also a second year DNB resident from Vishaka Eye Hospital, Vishakhapatnam. She'll be presenting a case of idiopathic intracranial hypertension or benign intracranial hypertension. And mentors today, we have Dr. Bishwajit. He is the HOD, Head of Department of Cornea Services at Arvind Eye Hospital, SV Arvind Eye Hospital, Tirupati. He is the mentor for Dr. Akanksha. And we have Dr. Jamima. She is a consultant for cataract, cornea, and refractive services at Vishaka Eye Hospital, Vishakhapatnam. She is the mentor for Dr. Srinavya. So without wasting much time, Dr. With your permission, Dr. Ravikiran sir, shall we go ahead with Dr. Akanksha's case?
Yes, sir. Yes, sir.
Yes, Dr. Akanksha, you can I can share your screen and start your presentation.
Okay, sir.
I request all of you to mute yourself and then unmute only when you want to talk. Go ahead, Dr. Akanksha.
Yes, sir. Is it visible, sir?
Yes, very much visible. You can go ahead.
Okay, sir. Good evening, everybody. I'm Dr. Kanksha, second year DNB resident from SV Arvind Eye Hospital, Tirupati. I will start with my case. A 60-year-old male named Vijaya Ramaraju, farmer by occupation, resident of Kadapa, came with chief complaints of growth of a mass in a white part of left eye since 1 year, foreign body and burning sensation in left eye since 5 months, and defective vision in both eyes since 4 months. Patient history of presenting illness. Patient was apparently normal 1 year back when he noticed growth of a pink mass in his left eye towards the nasal side, which was insidious in onset and gradually progressed to the current state. He complains of a constant feeling of something present in eye ever since he has noticed the growth. There is no history of pain, redness, or watering associated with it. Family history is not significant. Past history, there is no history of diabetic mellitus, hypertension, asthma, tuberculosis, or epilepsy. Ocular history, there is a history of use of glasses. There is no history of previous ocular surgeries, no history of ocular trauma, no history of diplopia. Personal history, the diet is mixed, appetite is normal, sleep is normal, no history of any substance used. Examination. A 60-year-old male, moderately built and nourished, conscious, cooperated, and well oriented to time, place, and person. There is, in general examination, no pallor, icterus, cyanosis, clubbing, or lymphadenopathy or edema was noticed. Blood pressure is 110 by 70 mmHg with pulse rate of 84 beats per minute. During ocular examination, the head posture was straight and erect, facial symmetry was symmetrical, ocular symmetry was symmetrical. This is a photo of my patient of left eye presenting with a mass on the nasal side. I will start with the left eye, which is the affected eye first. Left eye uncorrected visual acuity is 6/12, improving to 6 partial. The uncorrected near vision is N18, correcting to N6. Ocular movements are full and free in all direction. Eyebrows are normal, orbital margins are normal, eyelids are normal, eyelashes are normal, lacrimal apparatus, punctum is normal, skin over the lacrimal sac is normal, rho plus test is negative. Conjunctiva, a pink fleshy vascularized wing-shaped fold conjunctiva extending from the palpebral aperture of nasal side to the cornea was noticed. Cornea, a fold of conjunctiva encroaching cornea approximately 3 mm from limbus was noticed. Anterior chamber is normal in depth and clear in content. Iris is normal. Pupil is round, regular, and reactive to light. Lens showed early lens changes. I will start with anterior segment of my right eye. Right eye uncorrected visual acuity is 6/12, improving to 6/6 partial, with near vision N18 improving to N6. So ocular movement is full and free in all direction. Eyebrows are normal, orbital margins are normal, eyelids are normal, eyelashes are normal, punctum is normal, skin over the lacrimal sac is normal, rho plus is negative. Conjunctiva is normal in right side, cornea is clear, anterior chamber is normal in depth and clear in content, iris is normal, pupil is round, regular reactive to light, and lens shows early lens changes. The fundus examination in slit lamp with 90D showed in left eye, media is clear, disc is normal in size, shape, and color, well-defined margins of cut this ratio of 0.4 with healthy NRR, healthy neuroretinal rim. Vessels, vessels arise from the center of disc branching dichotomously. Background retina appears normal, macula appears normal, and with foveal reflex being dull. On the right side, the media is clear. Disc is normal in size, shape, and color with well-defined margins with cup-disc ratio of 0.4 with healthy neuroretinal rim. Vessels arise from the center of disc branching dichotomously. Background retina appears normal. Macula appears normal and foveal reflex is dull. Summary of my case, a 60-year-old farmer comes with complaints of a growth of pink fleshy mass in the left eye since 1 year, associated with foreign body and burning sensation for 5 months. On examination, a wing-shaped fleshy fold of conjunctiva encroaching upon the cornea approximately 3 mm from limbus is seen. My diagnosis suggests left eye a progressive nasal pterygium with incipient cataract and right eye having incipient cataract. Mhm. So, hello, sir. Is it?
Yeah, you have done a very nice presentation, Dr. Akanksha.
Yes.
One one suggestion which I
Yes,
can
sir.
give you is there is some grading of the pterygium, isn't it?
Yes.
So once you diagnose it as a pterygium clinically, you can as well grade it, and when you
Yes,
present
sir.
it looks better.
Yes, sir.
Yeah. And what else can appear as a mass at the limbus?
Sir, as a differential, it can be a pseudopterygium.
Yes,
It can present as pingicula
yes,
or any limbal dermoid
yes. Very good.
or nevus or OSSN.
Yes. Anything else?
Mm. Any limbal nodule, sir? Flectin
Yes.
or as OSSN.
Yes. Anything else? Any nodular episcleritis?
Yes, if it is
For
more inflamed,
foreign body granuloma?
foreign body granuloma, or if it is
These
more
all the
inflamed, The episcleritis nodular.
These are all the differential diagnosis which we ought to offer anybody. Okay. Suppose if it, can you elaborate and how did you come about the differential diagnosis of all these conditions? How do you dissect out that this lesion is only pterygium and it is nothing else
Yes, sir.
clinically?
Sir,
Clinically,
sir, first my demographical profile of the patient. He being in the age group of 60-year-old and working as a farmer with
yes,
with no positive history of any ocular trauma or
yes,
any chemical injury, which
yes.
ruled out any cause of pseudoterism, which is more of an inflammatory inflammatory um, uh, uh, origin. So it ruled out my pseudoterism, sir.
Yes.
Then when we come, pincula is more about how where the location of the mass is. This mass was encroaching over the cornea till 3 mm. Then when we talk about limbal dermoid, the limbal dermoid is duration. It should be present from the birth. It started my mass started since 1 year back, which got progressed in last 5 months, and the location will be limbal at limbal position for the limbal dermoid. So, so
Pseudoterism is an inflammatory condition involving which tissue?
sir, it is involving majorly conjunctiva, the bulbar conjunctiva, or and the any it is basically involving the conjunctiva part, sir, or any marginal erosion is there over the cornea. If previous any corneal ulcer has been happened, if any marginal corneal ulcer which is attaching into the from conjunctiva and the fornix. So it is basically a
So inflammation
inflammatory
can be there in the cornea as well as the conjunctiva in either
conjunctiva.
cornea or conjunctiva or both. Okay.
Yes, sir.
So yeah, how will you differentiate an OSSN from a pterygium?
Sir, OSSN should it may be associated with pterygium also. To differentiate it, we should OSSN should have a feeder vessel. Then it can the location of the OSSN can differ. In pterygium, it is basically on the palpebral
అడగాల
part or
అంటారా ఓకే ఓకే
and if we want to differentiate more elaborately, we can also do ASOCT. In ASOCT, when we talk about OSSN, we will see hyperreflective epithelium, which more certain hyperreflected epithelium will be present in OSSN, which will be more thinned out in pterygium.
Hello.
Welcome, Dr. Rajan Prasad.
సార్ పర్మిషన్
Yes, sir.
మేడం డాక్టర్ వాట్ ఆర్ ది డిఫరెన్స్ బిట్వీన్ సూడోటెరిజియం అండ్ ట్రూ టెరిజియం
The difference between pseudoterygium and pterygium is pseudoterygium can be present in any site. There will be some previous etiology related to it. Either it can be because of an ocular trauma or any chemical injury or any previous corneal ulcers. And pseudoterygium won't be proper wing shaped. It can be in any form, any shaped, arising from anywhere, any site of the any site. Then we can do a probe test to differentiate it whether it is pseudoterygium or pterygium. In that probe test, the probe will pass on from pseudoterygium, since it is only the conjunctival part, and pterygium it is involving conjunctiva encroaching into the corneal
వాట్ ఇస్ ది
three
ట్రీట్మెంట్
layers.
ఫర్ సూడోటెరిజియం
Pseudoterygium usually, sir, it does not progress.
ఓకే వాట్ ఇస్ ది
So
ట్రీట్మెంట్
No, if you don't know, just say pass. Don't worry.
Then pass it.
yes,
You do not. So,
So
hello?
if you exercise it and take the graft from the same eye, again it will adhere to this there. So better to go
So
for
you,
amniotic membrane. Okay.
Yes.
you have to treat the
Sound
cornea as well. You have to treat the
It can be-
cornea as well after removal of the pseudopterygium. You can do a superficial keratectomy and a small graft also can be corneal graft, a superficial corneal graft also can be placed over that area. Nowadays,
Can I ask something?
yes, sir. Certain.
Yes, sir.
Is my voice audible?
Yes, sir. Yes, sir.
Yes.
Doctor, where is the presenter?
Dr.
Presenting.
Aksha.
Dr. Akanksha.
Yes, I'm here, sir.
Just now I joined. I didn't heard what you presented in the beginning. So, did you talk about any pathophysiology of pterygium?
No, till now I have not talked about pathophysiology of pterygium, sir.
Can you explain the pathophysiology?
Sir, usually pterygium is, when we talk about etiopathogenesis of pterygium, it is a major factor responsible for it, extensive UV exposure, and the climatic condition, which will cause alteration in the limbal stem cells. That limbal stem cells will altered and formed into pterygium cells, which causes sir, epithelialization. There will be same that pterygium cells fibroblast formation will also form. There will be hyperplasia of the goblet cells with the squamous
Excuse me.
metaplasia.
There is no such term as pterygium cells. Where
Pterygium.
you are telling in general, or did you read in any book? Till now, we didn't heard about pterygium cells.
Hello?
What happens when the
Sir,
eye is exposed to ultraviolet radiation?
Dr.
Sir, they
Bishwajit
will be.
wants to talk.
sir, can I take a word, sir? Like,
Yes, Dr. Bishwajit.
yeah, sir, regarding the pterygia cells, sir. So there are recent articles which are showing that whatever the pathophysiology was initially studied, so now the new pathophysiology has come. So which shows that initially what we were thinking was it was because of the failure of the limbal stem cells. But the recent studies, what it shows that it is because of the limbal reorganization, not failure of the limbal stem cells. So what happens? Usually the limbal stem cells get altered to pterygium-like cells. So these are initially called as Fuchs flakes, which was initially described by Dr. Fuchs long back. So now this again this new theory has been postulated that there is limbal reorganization and there is alteration in the limbal stem cells, which are newly called as pterygia cells. And these pterygia cells are actually have migratory and proliferative capacities. And they are rich in P53 cells and other
Yes.
fibroblast cells. So these are the things which helps in the progression of the pterygium. So this is the actually the new pathophysiology which recently I also went through. So that's why I also told to give Akanksha that article to read. So that's why she's telling regarding the pterygia cells.
Yes, sir. That's
But what
that article we have
my
also gone through.
Yeah,
Yes,
yeah,
sir.
please.
We came across that.
what I want
Nice to
to
mention.
explain is actually on exposure to ultraviolet. This is according to standard theoretical knowledge. What happens is when eye is exposed to ultraviolet radiation, uh, one thing happens, that is conjunctival ultraviolet autofluorescence. So this conjunctival ultraviolet autofluorescence will cause elastotic degeneration in the conjunctival stroma. This elastotic degeneration once happens, then the fibroblast will proliferate to halt that process, and they will cover the pterygium and forms the head of the pterygium. These migrated fibroblasts. That is what I read from the standard literature. So
That-
this
yeah,
elastotic degeneration along with
Fibrovascular
fibrovascular
elasticity.
proliferation
yes, sir. Yes,
together
sir.
forms the pterygium.
Yes, sir. That is absolutely right. Yeah, you're absolutely correct, sir. So these things, the new literature, what it's showing, these the same thing also. The stromal fibroblast, what you told, sir. These things are also included in that pathology, along with the
But
Sterigia
the
cells.
expression
So
of P53 is a new finding, sir.
yeah,
Yes, sir.
Yes, with
Uh,
your permission, let us go ahead and ask some questions to Dr. Akanksha.
yes, sir. Yes, sir. Dr. Akanksha,
Yes,
Hello.
sir.
can you explain why there is a diminution of vision in your patient in the left eye?
Um, so looking at my grade of pterygium and as such, I feel my patient diminution of vision was one was because he was having incipient cataract, early lens changes, and he's already using presbyopic glasses.
Okay, pterygium will not cause any diminution of vision. If it
It do
causes,
cause, sir.
how can
It
it cause?
it do cause. One is by inducing astigmatism. Second is if it is encroaching and encroaching over the pupillary axis.
Type of astigmatism is common. Akanksha.
Yes, sir.
Which
Which
type
type
of
of
astigmatism?
astigmatism?
So with the rule, astigmatism is caused.
Why?
Yes.
As
We-
my pterygium usually occurs in the horizontal axis because it is more in the palpable area on the nasal side. So when it is like it is a fibrotic tissue which will cause a counter traction on the horizontal axis, hence flattening the axis. So the vertical axis will get steepened up and will induce us with the rule astigmatism.
No, vertical axis will remain the same, but the horizontal axis gets flattened. Yeah.
Flattened.
Yes. Just one suggestion. Please never refer to as your pterygium. Okay,
Yes, sir.
on the
Yes,
lighter
sir.
side. Yeah. It's a
Yes,
patient's pterygium, and let
yes,
us talk about patient's pterygium only. Okay,
She's
yes,
we
sir.
owning,
don't want you to have a pterygium.
she's
Uh,
Yes,
owning the
sir.
I-
patient. She's very concerned.
and
Take
uh,
care
Dr.
of
Ak-
her.
if
Dr.
you want to
Akanksha, define
assess,
the
if you
astigmatism.
if you want to
Dr.
assess the
Akanksha,
astigmatism, which investigation would you like to do?
Um, Sir, I will first check with for my K readings. I can go with A scan. If we can do with keratometry and we can have A scan to check it with my K
Any
values.
Yes, anything else apart from
Uh,
routine keratometry? If it is irregular astigmatism,
The recent one you can tell the recent mode of investigation.
we have that in our corner clinic, Akanksha.
uh, Pentacam, sir,
yes,
or
anything else?
ASOCT corneal topography. We can.
Yes, that's the answer. Corneal topography you can do, and you can as well do an anterior segment OCT also, and that will also rule out an OSSN if you are suspecting. Most of the times, the OSSN is suspected clinically, but we need to actually do uh, assess the uh, tissue also for histopathological examination post pterygium surgery. Okay. Yes.
Sir, good
So
evening, all of you, sir.
what are there any differences between progressive pterygium and regressive pterygium?
Yes, sir.
Yes.
When we talk about progressive pterygium, when we see the head part having a cap that is more of a semi-lunar shaped, cells are there or cap is there, then we will suggest it is a progressive pterygium. At the same time, if there is a iron deposition, if uh, if so
What do you call that line?
yes, Stocker's line.
Yes.
If it is there, it may suggest it is more of a long-standing pterygium. So it will tell us how it is more of a long-standing pterygium, which is not progressing as such because of the long-standing nature of the pterygium, the iron deposition has taken place.
Where else do you see a Stocker's line apart from a pterygium?
So you do not know if we can pass.
You can pass.
Sir, I'm not remembering.
You are not able to
Can
recall.
you explain the where, clinically how you decide that the pterygium is progressing?
Clinically, I clinically I have to see the grade of the pterygium. If it is more if it is 2 mm and more, it is encroaching over the cornea, and it is having a if I can see a white cap, so I can go forward. It is more of a progressive pterygium. With my patient history, if they are also suggesting it started growing more aggressively in last few months, they're observing it more evidently it is growing. So I can suggest it is more of a progressive nature of a pterygium.
Apart from that, the definitive points are see the presence of corneal epithelial irregularity and opacification of Bowman's membrane and the proliferation of blood vessels over the pterygium and mild inflammation. So these are the strong points that the pterygium is progressing.
So what are the complications of pterygium?
Sir, the complication of pterygium can be recurrent inflammation, constant feeling of foreign body sensation, um, foreign body sensation and irritation, then scarring of the cornea, and astigmatism. The refractive error it is causing. Then, if it is encroaching pupillary axis, defective vision.
Can a pterygium occur over the temporal area?
Yes, sir.
Yeah, if it occurs in both nasal and temporal regions, what would be the term you prefer to use?
Double pterygium, sir.
Yeah.
All right. And my question is why it occurs many times on nasal side? Any explanation?
Yes, sir.
Why pterygium is most common on nasal aspect?
Differentially, it
Sir,
occurs.
the light falls on the nasal bridge, which it gets reflected on the nasal side, hence causing more preponderance on the nasal side.
Light falls
No, the
on the
correct explanation is
temporal limbus and sclerotic scatter happens, and the effect is seen in the nasal side.
see what happens is the tear films, the tear film they will be drained through the puncta, so they will be pulled at the nasal canthus. So thus the tear film will act as a small convex lens. So when that person is exposing to sunlight, the UV rays will concentrate more on that area and evoking the pterygium formation.
Now, what are the different modalities of treatment of pterygium, doctor?
Sir, One is our medical modality. If the pterygium is not aggressive, we can, and patient is young by age, we can, and it is inflamed, we can treat it with medical modalities first, with giving lubrication, or if it is too much inflamed, we can start with low dose steroids, topical steroids. If patient is requiring surgery, we will go forward with surgery, sir, in which we can do conjunctival pterygium excision with conjunctival autograft. Then earlier they used to do bare sclera technique. Then we can have conjunctival limbal autograft. We can have pterygium excision with conjunctival autograft with glue.
Any other graft material apart from conjunctiva?
Amniotic membrane transplant also we can do. Then,
Conjunctival auto rotation.
yes.
Sir is suggesting. Yes.
Auto rotation flap.
So, why do you have so many surgical procedures for a single condition? Why do you think
Sir, because
that
of
there is
the
a necessity
recurrence
of?
nature of the pterygium.
So, nothing is perfectly able to answer the pathology. Okay. So far, the best results are gained by putting a graft and filling the gap, whatever you have created there surgically, okay, by excising the pterygium. Okay, so this graft has transformed the outcome in many ways. Okay, so the recurrence rate. Can you tell the recurrence rate of a bare sclera technique versus the graft? Any graft, whether it is autoconjunctival graft, rotation graft, or amniotic membrane graft, or whatever. Is there a difference or not?
Difference is there, sir. Bare sclera, I don't remember. With autograft, it is 3 to 7%.
Yes.
No, it is still more. See, with
But
bare sclera, it is around
is the
50 to
highest.
80%.
Highest
Yes,
rate.
sir. Yes, sir.
And with graft, it is around 5 to 15% recurrence rate.
Yes.
So let us conclude this case.
Yes, sir.
Sir, doctor, one question.
Yes.
Madam, you described diabetes in past history. Is it comes in the past history?
No, sir. Systemic history should come.
Huh?
Systemic history it should come, sir.
Systemic history or personal history or medical history?
Personal history, sir.
One more thing is, you described that one is in the diagnosis. What is that cataract?
Recipient.
Early lens changes, incipient.
Huh? What is that cataract? You described some cataract, no, in the diagnosis.
Incipient cataract, sir.
I will confirm that one. You particularly mentioned, no, NCC.
Sir, to confirm whether it is incipient cataract, whether the patient is having,
How
whether the
will you
patient was
examine with a slit lamp or a
See, you
retinoscope
see
or
under
or
retroillumination,
an ophthalmoscope?
You dilate the
how it
fundus, you see
looks.
the fundus with the distant direct ophthalmoscope, where you will
Yes.
see the triangular black opacities against red background.
Yes.
That is the confirmation.
Yes,
Yes.
Okay.
they
Okay,
are
sir.
called raids.
So shall we go ahead with the second
Yes,
case?
sir. Yes, sir. Yes, sir.
Thank you.
Good
Yeah,
presentation, Dr. Akanksha.
Yeah.
Done a good job. So Dr. Srinavi, are you ready with your case?
Yes, sir.
Yes, you can start sharing your screen.
Actually, the opening batsmen receive many bouncers.
Sir, is it visible, sir?
No, yes,
Yes,
yes, go
yes,
ahead.
yes.
Okay. So good evening all. I am Dr. Srinavya, second year DNB resident from Vishaka Eye Hospital. My mentor is Dr. Sheikh Jamima ma'am. So a 13-year-old boy presented with complaints of double vision and headache for the past 5 days. Headache was acute in onset, progressive, diffuse, and more severe upon awakening and exacerbated by coughing or bending forward. No associated pulsatile tinnitus or transient visual obscurations were mentioned. Diplopia was binocular, horizontal, and separation of images were more pronounced when looking onto the left side and when viewing distant objects. The diplopia completely resolves upon covering either of the eye. No history of trauma, no history of fever, neck stiffness or recent vaccination, no history of diarrhea, vomiting or ear pain, no history of convulsions, loss of consciousness, dysphagia, dysarthria or ataxia, chronic cough, weight loss, no history of snoring, gasping or no pauses in breathing during sleep. Past history was no similar episodes in the past, no significant past history, not on any regular medication, no known allergies, nil significant family history. Personal history, he follows a mixed diet and normal bowel and bladder habits. On examination, he was conscious, oriented to time, place, and person. The BMI showed 27 kilogram per meter square, that is obesity class 1. No pyruvectorous cyanosis, clumping, or lymphadenopathy edema. Vitals were stable and systemic examination was within normal limits. Motor system, sensory system, reflexes, gait, and cerebellar function tests were normal. Cranial nerve examination, all cranial nerve examination was within normal limit except the 6th cranial nerve, which I will mention in detail later. Ocular examination, normal head posture, ocular symmetry was lost due to inward deviation of left eye. Hirschberg test, right eye, light reflex falls on the center of pupil, and left eye, light reflex falls between the temporal border of pupil and limbus. 30 degree of ESO deviation was noted. Extraocular movements, here we noted there is a limitation of on abduction, that is 75% of limitation of muscle was noted on abduction in left eye and mild restriction in levo elevation. Mild overaction was noted in right eye on adduction. And on cover-uncover test, left esotropia in primary gaze was noted with secondary deviation being significantly greater than the primary deviation. Worth 4-dot test was done and uncrossed diplopia with 5 dots were noted. 2 red dots and 3 green dots were mentioned by the patient. Diplopia charting showed uncrossed diplopia, which was the distance between green and red bar was more significant on left extreme gaze, and also on levo elevation and depression we were noted and was charted. And visual acuity was 6 and 6, it was normal. Slit lamp examination, anterior segment examination was normal with no RAPD noted. On posterior segment examination, we could prominently find annular blurring of disc margin with obscuration of blood vessels on the disc and leaving the disc, and hemorrhages noted inferiorly. According to the Frisson classification, it comes on to grade 4. Then this same finding was noted in left eye also. With the color vision being 17, patient was able to read 17 out of 17 plates, and it was within normal limits. Provisional diagnosis was emetropia both eye, papilledema, abducens nerve palsy left eye. Probably it may be due to intracranial space occupying lesion or idiopathic intracranial hypertension. My differential diagnosis were intracranial space occupying lesion, idiopathic intracranial hypertension, pseudopapilledema, cerebral venous sinus thrombosis, hydrocephalus, or meningitis. So moving on to the investigations, first we did kinetic confrontation test, and fields were grossly full to finger counting in all 4 quadrants bilaterally, and no field constriction was noted. The visual field testing 30-2 was done, noting the fixation loss were 15 out of 19 in right eye and false positive was 43%. and left eye it was 15 out of 16, and 69% false positive errors was noted. So this test was less reliable or not reliable, and the test was done 3 times. MRI brain and orbits were done. It showed bilateral optic nerve head protrusion, papilledema, optic hydrops on both sides. MR venography study showed hypoplastic left transverse and sigmoid sinus, complex and focal narrowing of lateral aspects of both transverse sinus. These findings were correlating with raised intracranial tension or idiopathic intracranial hypertension. Here we can see the kinking of optic nerve and posterior globe flattening. So the final diagnosis was idiopathic intracranial hypertension with secondary left abducens nerve palsy. The patient was started on oral acetazolamide 250 mg twice daily for 3 weeks. He was advised weight reduction as he was obese class 1, was referred to neurologist for further management. Sir, should I go to discussion?
What was the BP?
BP was within normal limits, sir.
How much?
120/80.
Really? You never mentioned that?
Yes, sir, mentioned. 110/7. One 10/70, sir.
Hmm. Right. Kiran sir, Rajendra sir, all yours.
Yeah, see, basing on the MRI, this thing only you are concluding that it is benign idiopathic intracranial hypertension. Is it correct way? Any other
Sir,
modalities are there?
according to modified Dandy criteria, there
Yes,
should be
modified Dandy criteria. Yes.
yes, sir. So the patient should have symptoms of elevated intracranial pressure, that is headache,
Yes.
vomiting, etc. Then no focal neurological deficit should be there except abducens nerve palsy. Then lumbar puncture should show elevated opening pressure that is more than
No, I think it's not the sixth nerve pulse. It is papilledema. Papilledema can be present without with the raised ICPs,
Okay,
not
sir.
sixth nerve palsy.
Okay, sir.
The neurological image is normal, no?
Sir, there was esotropia, sir.
Huh?
Other cranial nerve
Doctor?
examinations.
Neurological imaging
Yes,
is
yes,
MRI
yes,
is normal only, sir.
yes, yes.
Yes.
Doctor, there is papilledema in both eyes, and you don't see any intracranial space occupying lesion or any venous occlusion, central venous sinus
Yes, sir.
thrombosis, or any
Thrombosis.
other condition that could be
Causing
causing a secondary intracranial hypertension.
hypertension.
Okay, so you are going in favor of idiopathic intracranial hypertension. Okay, so in the symptoms, you did not mention about tinnitus.
Sir, there was no associated tinnitus. I
No,
mentioned.
no, you did not mention that. You
I
ought
think
to mention that.
I
That
think
in this
mentioned.
case. In this case, you ought to mention that, because that is the most disturbing symptom for the patient.
Yes,
Apart from the headache, the patient will have this tinnitus, and more disturbing is the diplopia.
yes, sir.
Okay, so can you tell what are the diplopia rules?
You can stop sharing the Srinovia. Yeah, now answer what is the diplopia rules.
Sir, diplopia will be horizontal and binocular. As the left lateral rectus palsy is there, the patient will have straight horizontal diplopia only, and it will be more pronounced on the looking onto the direction of the muscle weakness, and it will be binocular.
The false image belongs to the
Sorry, sir.
affected eye. The false image belongs to the affected eye. Okay, that is point number 1. and the false image is the outer image. Okay, because the normal eye
Normal
is trying
fovea,
to
it will
look
be
at the
formed
uh,
up, extra
yeah,
foveal.
yes, yes. So the paralyzed eyes image will be ignored by the brain, and it will not be processed. It will appear blurred. That is one thing. And you mentioned correctly the third point. The diplopia is maximal in the direction of the action of the paralyzed muscle. Okay, so these are the diplopia rules. This is the basic. Okay, here you have a horizontal crossed diplopia or uncrossed diplopia in your patient.
Uncrossed diplopia, sir. Esotropia was there, so
Okay,
uncrossed.
why do you call it uncrossed?
So while testing, we'll put the red filters in front of right eye and green filter in front of left eye. Patient will identify red bar in right side only and green bar in left side. So we'll say this is uncrossed.
Okay, so then with a patient having a bilateral optic disc edema, which you feel as a papilledema. Okay, can you explain the presence of this esotropia and the recent onset of diplopia?
Sir, on as we seen in MRI, there was left side there was hypoplastic transverse and sigmoid sinus. So the drainage of
No,
CS.
that is due to the raised intracranial pressure. Raised intracranial pressure leads to the appearance of the almost most of the radiologists they report it as a hypoplastic. Okay, but that's not a hypoplastic, but that is the compression of these sinuses. Okay, yes. What else?
Sir,
Why
because the
why there is a sixth nerve palsy in
sixth
a
nerve
case
is
of
the
raised intracranial pressure?
yes, sir. Sixth nerve has the longest intracranial course. And also it has a deviation in the petrous part of temporal bone. It takes a deviation and it's
Okay.
more prone for compression when the dural meninges are like having more pressure, and this gives a false localized sign.
What is coning?
Sir,
What is coning? Coning of the brain.
sir, basically herniation.
Yes.
You are right.
Yes.
When the intracranial pressure increases, herniation of brain can occur through the uh, major
Foramen.
foramen magnum.
Yeah, if it occurs through the foramen magnum, you call it as central coning.
Central cone.
Okay. Yes. There is another coning called as a temporal coning, where the temporal lobe, the inferior and nasal part of the brain, it yeah, as a result of subdural hemorrhage, it causes compression of the ipsilateral third nerve first, and then the opposite side third nerve next. Okay, so yeah, that is third nerve. The central coning, the brain stem is pushed down,
Down.
isn't it?
Yes, sir.
So the where does the sixth nerve exit from the brain stem?
Right. Pons,
Very
pons,
thin,
sir.
yes, yes,
Behind
pons.
pons.
Yeah. So and it sends over the which part of the bone? Dorsum sellae.
Yes, sir.
Okay, and it passes through which ligament in the uh, uh, beneath which ligament it passes through into
And
the
canal,
cavernous
canal
ligament.
also, canal.
Yes, canal and ligament. Both you have to tell.
That Petrus, sir, but sir, I'm not sure,
Duralos
sir.
canal, Duralos canal.
Yes, sir. Duralos canal.
Where it is fixed,
Petroclinoid ligament.
and
Okay,
Duralos
so
canal.
yeah.
Where it is fixed. The apex of the petrous bone, it is fixed, sixth nerve is fixed. So any intraocular pressure rises, it stretches that one, sixth nerve.
Yes, yes.
That's why there is no localizing value for sixth nerve pulse.
Okay,
So
sir.
any pressure can cause any side sixth nerve paralysis. So that's why it doesn't have any localizing value. Whereas the third nerve, it first gets affected in a temporal coning. It gets affected on the same side of the subdural hemorrhage. Okay, so neurosurgeons, before the advent of and availability of the CT scans and all, they used to assess for these signs clinically, and they used to localize the presence of subdural hemorrhage or extradural hemorrhage based on these findings in the case of head trauma. Okay, so the sixth nerve palsy we have explained. You have explained the Friesen grading. Can you elaborate on Friesen grading?
That's
Yes,
one question. Is the sixth nerve palsy is nuclear or peripheral?
peripheral, sir.
Yes.
How can you tell that?
Sir, basically the lateral rectus is involved, sir. So,
No, if it is nuclear, what else
brainstem,
will you see?
yes, sir. Brainstem involvement, brainstem signs will be there if it's like if it is involved from
Which other cranial nerve will be involved if it is a nuclear lesion?
fourth.
No, the fourth is in midbrain.
Sixth is in the spons.
5, 6, 7, 8 will be there in pons, sir.
Okay, so you go back and yeah,
Yes, sir,
go back and read about the anatomy of sixth nerve.
Okay, sir.
Okay, yeah. Can you elaborate on Friesen grading?
Yes, sir. Grade 1, grade 0 will be no blurring of disc margin. Grade 1, nasal blurring of disc margin. Grade 2 will be annular blurring of disc margin. Grade 3 will be obscuration of annular blurring of disc margin with obscuration of blood vessels leaving the disc. Grade 4 will be obscuration of blood vessels on the disc and leaving the disc.
Grade 5?
Grade 5 will be overall obscuration and elevation of the disc will be seen. High elevation of the disc.
Okay.
Doctor, you told primary deviation and secondary deviation, no?
Yes, sir.
What is primary deviation? What is secondary deviation?
Yes, sir. When we occlude the eye which is involved, that is in this case left esotrophic eye, when we occlude the eye, the amount of deviation will be less as compared when we occlude
When
the.
you occlude the eye, you want to occlude the eye?
No, sir. Like when we are doing alternate prism cover test, we'll get this finding. That is, we'll see the deviation when the affected eye is.
When you are testing primary deviation, which eye is fixed, which eye is measured?
We'll measure the affected eye.
That means fixing eye is?
Fixing eye is not. We will not. That is free, sir. That is, we will not measure that eye. That is the amount of deviation will be less when we when we see for the deviation in affected eye, and this is explained by the Herring's law, sir.
Generally, this is a secondary deviation. Is deviation of the sound eye when paralytic eye is fixed. Primary deviation is the deviation of the paralytic eye when sound eye is fixed. Okay.
Okay.
Got it?
Yes, sir.
Primary deviation is deviation of the paralytic eye when sound eye is fixed.
Sir has learned the basics in a perfect manner. That ought to be the aim for all of you youngsters. Okay. So the way which sir is asking questions, as well as the way he is explaining the basics. Okay. You just learn from it. Okay.
Thank you, sir.
Yes. Yeah, doctor, which investigation would you like to do apart from an MRI? You have the access and your patient has the affordability and everything. Okay, you come across a patient who has bilateral optic disc edema. And what are all the causes of bilateral optic disc edema, doctor?
Sir, elevated, accelerated hypertension, pseudopapilledema, anterior optic neuropathy, which can be ischemic, infiltrative, and compressive. Then it can be mitochondrial disorders like Leber's, hereditary optic neuropathies. Then local causes like uveitis, posterior scleritis, hypotony. These causes can be there, sir.
Oh, hypotony and all, they will not be bilateral, isn't it? They are causes of unilateral optic disc edema. Even Leber's also, it is sequential. Both eyes will not be simultaneously involved. Okay. So, the hypertensive retinopathy, the thyroid eye disease, and you have these keratoconus fistula and cavernous sinus thrombosis. Okay, which are clinically easily distinguished because you have a proptosis in cavernous sinus thrombosis and you have a pulsatile proptosis in this keratoconus fistula, and you have the associated signs in the eyelids in case of thyroid eye disease.
Yes.
Okay, so they can be easily ruled out. The only thing which you have to examine is blood pressure. Okay, number one is blood pressure. Number two is ultrasound B scan.
Yes, sir.
You have to do the ultrasound B scan to rule out which one, which item.
Sir, in ultrasound B scan, we can see optic disc druseness, and it can also be used. A scan also be used for the 30-degree test, sir.
Yes, very good.
That is optic nerve sheath diameter on 30-degree gaze. On primary gaze, we'll measure the diameter, and on extreme gaze, if there is less than 25% decrease, that is a positive.
Very good, very good. Which part of optic nerve will you image? How
Sir,
far back from the optic disc?
sir, in sir, we can just see the posterior part, that is just see just posterior to the globe also we can measure, and sir, I don't remember the correct measurement that is in
Okay.
between the chiasma and
Okay. So you have to image the patient. You have to somehow explain the patient the situation, and you have to ask the patient to go for a neuroimaging. Which neuroimaging is the best modality in these cases?
MRI and MR venography.
MRI with MR venography is the standard. Okay. Yes. Why MRV?
Sir, in case of sinus thrombosis, and we can rule out any obstruction like stenosis or
Yes.
thrombosis involvement.
Yes.
Everything will be.
Yes. It's a very good answer. Uh, Suppose you are trying to diagnose an idiopathic intracranial hypertension. Okay. So which are the findings you expect to see in an MRI?
Yes, sir. Optic nerve head protrusion can be seen, that is papilledema. Then optic nerve sheath diameter will be elevated, posterior globe flattening, then empty cella sign. Then posterior tortuosity of the optic nerve will be more.
Yes. Yes. And this hypoplasia of the transverse sinus and all. Okay. Yes. And would you like to ask the radiologist for any IV contrast or not? No, that's the decision of the radiologist only.
Yes.
Okay, but you will discuss. Okay, will it be required in majority of the cases? If
Not
required,
required.
what will be the conditions which require an IV contrast?
Basically,
Just
to find out the
go and check
occlusion.
with your radiology postgraduates.
Okay, sir.
Okay, yes, and You want to observe this double vision, or you just want to leave the patient like that?
Sir,
Just giving a diagnosis.
temporarily we can advise patching
Yes.
or Fresnel. If it is mild to moderate diplopia, we can advise Fresnel prism, or if it's severe, we can advise patching. But the disadvantage is the patient will lose the stereopsis,
Yes.
and like gradually as the pressure comes down, this symptom also will reduce.
How long will you wait for a squint surgery if it persists? It's a
Not sure.
paralytic squint, isn't it?
Yes, sir.
Yeah.
Not
Usually it resolves. Okay. But just for the sake of asking you a question, we are asking this.
Not sure, sir.
Runs for 6 months usually.
Yeah. Any
See,
paralytic,
coming
any
coming
paralytic
back
squint,
to
we have to wait for 6 months before
Okay.
putting a knife. You can as well temporarily, you can as well help the patient out by giving a botulinum injection into the medial rectus.
Okay, sir.
Yeah, that will weaken the medial rectus, and that will help the esotropia temporarily.
For some time.
But,
For some
yeah,
time.
for some time. Yes.
Okay,
Sir,
sir.
any questions, sir? Any other questions?
can you tell me the order of symptoms that a patient tells in case of IIH? Let us come back to this original topic.
Sir, patient due to the elevated intracranial pressure, patients will have that symptoms like headache, pulse, projectile vomiting. Then this due to involvement of nerve, patient might have diplopia.
See, you have forgotten one important symptom that is seen most commonly in papilledema. What is it?
Straight.
Early
Transient,
morning. Early morning.
Early
transient
morning.
visual obscuration. It is very
Yes, sir.
important
Yes.
symptom in case of IIH that you didn't mention in the case sheet also. After headache, it is the second most common symptom. Then followed by horizontal diplopia, tinnitus, all will come later.
Yes.
What is the field defect in this case?
Sorry, sir.
What is the field defect?
There was
You
no
have taken
field
30 days to
defect.
know.
On confrontation test, we didn't note any field constriction.
Okay, 30 days to you have taken, no?
Yes, sir. It was not reliable.
But what type of field defect you will see in papilledema?
Sir, enlargement of blind spot, then nasal step, then it can progress to arcuate scotoma, then overall peripheral constriction of the field.
In papilledema?
Yes, once peripheral constriction of field starts, what is your assessment of the progression?
It's progressing and involving the nerve fibers.
Yes.
So.
And it is going into atrophic stage.
Yes, sir.
Yes. Yes. And which
Good.
modality of latest modality can you assess? And you can as well document.
Sir, OCT, nerve fiber layer thickness also we can take.
Yes. Anything else in the OCT?
Fundus fundus autofluorescence.
No, that's useful only in optic disc drusen. Apart from this nerve fiber layer thickness, you can sequentially assess whenever the patient comes, the elevation and the edema of the RNFL, whether it is coming down or not, you can assess. And you can also assess the visual function by doing a 10-2 in these patients. Okay.
Okay.
So 30-2 will give you the essence, and the 10-2 will give you the central vision, and the ganglion cell layer
Okay.
in the OCT, ganglion cell layer thickness. Okay, in the OCT, if it starts decreasing, okay, if it starts decreasing, then you are more likely your patient is going to lose the vision, maybe forever. Okay, so
Okay.
that is one important thing which we all have to look for whenever we are trying to follow up with these patients. The visual acuity and the visual field and the uh, OCT finding of ganglion cell layer thickness. Okay.
Clinically,
So,
how do you assess the elevation of the disc?
Let us conclude.
yes, yes, sir.
Clinically, how do you assess the elevation of the disc?
Sir, through direct ophthalmoscope.
Ah,
Yes.
Yes.
How do you assess?
Sir, so 1 mm elevation can
1 mm?
a 1 mm elevation in the disc is
How do you know that it is 1 mm or 2 mm or diopters? No, usually it is the
yes, sir.
the direct ophthalmoscope was measured in diopters, no?
Yes, sir. Through
2
the
diopters or 3 diopters, 1 diopter.
yes. 1 mm elevation is equal to 1 disc diopter.
How do you know that 1 mm?
Sir, using
Ophthalmoscope is not there 1 mm, no? Direct ophthalmoscope, there is no measurements like 1 mm.
sir, I'm telling the disc diameters.
You have to only measure in disc diameters.
Diopters.
Diopters.
Okay. So you are going to focus on the surface of the optic disc, and you are going to move the recurse of the direct ophthalmoscope, the one in which all these lenses are there, that is called recurse, and you are going to focus on an adjacent area of the retina,
Yes.
normal retina.
Yes, sir.
Okay, so the measurement will be how much you have rotated the recurse.
Yes.
Okay, so if it is 3 diopters, it is 1 mm elevation.
Yes, sir.
Okay, if it is more than 3 mm, it is definitely papilledema.
Okay.
Because an optic neuritis will never cause an elevation more than 3 diopters.
Yes.
Okay.
What are the other differences from the optic neuritis?
Sir, optic neuritis can be unilateral or bilateral, and it can be caused due to any compression, inflammation. Then vision loss will be early in optic neuritis. Pain might be there. Then visual fields also.
Why there is a pain in the optic neuritis?
Sir, if it's inflammatory, I mean,
That too on movement.
Yeah, go ahead.
Looking up.
Sorry, sir.
Looking up on
Patient looks up, he experiences pain. What is the reason?
Superior rectus involvement, sir. As
How do you involve the superior rectus?
sir, inflammation of the optic nerve, as it is annulus of sin. As we can see, there is a superior rectus and medial rectus will be involved in such cases, sir. So on looking up,
No, it is a jura. That is the optic nerve comes under jura. No, that jura splits and one layer attaches to the opening of the optic foramen, and one layer continues with the optic nerve. That is fixed. Okay. Okay, verify it and you can you can understand.
So, can you explain the management of this case?
Yes, sir. As the patient was obese, we advised weight reduction, and there was no significant visual loss. We started on acetazolamide, that is carbonic anhydrase inhibitor, to reduce the intracranial pressure. And we refer to neurologist.
What is the dose?
Sir, in pediatric dose, it can be given as 15 to 25 mg per kg per day. Acetylcholamide, sir.
15 mg.
15 mg per kg per day.
Yes.
Is 60 kgs.
And adults?
Sir, adults 4 grams also, till 4, up to 4 grams also we can give, sir.
Yes. How long would you like to continue the treatment?
Sir, we have to follow up the patient with fundus photo, visual fields, and visual acuity, and we have to it should be a multidisciplinary approach with neurologist involving, and lumbar puncture also can be done as a temporary relief.
What is normal intracranial pressure, doctor?
10 to 18 centimeters of water, sir.
Yes.
When you say it is raised ICP,
More
how
than
much?
25. Yes, sir. In children, it is more than 28 centimeters of water. In obese children, it can be up to 25. In adults, it is more than 25 centimeters.
I think we will conclude.
Yes, sir.
No, sir, it's not at over. It's still a lot is there. In management, it's
Yeah,
not
but
over. What?
Which blood test would you like to ask the patient again and again once you put them on carbonic anhydrase inhibitors? Yes, electrolytes.
Electrolytes.
Yeah, you are right.
Which electrolyte? You are particularly.
Sodium.
Is it sodium, potassium, or chloride? Which one?
Sodium and
Which is
potassium.
more dangerous? Which is more
Potassium
dangerous?
is more dangerous, sir. Potassium.
Yeah. Here hypokalemia is there.
Hypokalemia is more dangerous. See, apart from acetazolamide, which other drug you use? Suppose acetazolamide is patient is not complain
Topiramate,
or
sir. Topiramate we can give.
Yes.
no. I am asking about carbonic anhydrase inhibitor like action.
Sir, topiramate and
Topiramate won't work.
furosemide.
Yes.
Yeah, furosemide is the second drug.
Yes.
Furosemide, yes. What is the purpose of topiramate? What
Sir,
is its main action?
Sir, it has anti-epileptic action mainly, that is GABA A enhancement and blockage of
In an IAH. In this case, I am asking.
yes, sir. Secondary carbonic anhydrase inhibition action is there, and weight reduction also is there, sir.
No, it most of relieves headache. It
Yes,
is nowadays it is they are using as anti-migraine medication, so it relieves headache, which is the most common in these cases. And also, as you said, it also acts as in weight reduction. Yeah, it gives some weight reduction. Suppose all the medical treatment failed, papilledema is continuing. What is the risk? What happens if the papilledema is long-standing?
So this papilledema induced optic neuropathy, optic atrophy, it can lead to in advanced stage, sir. So we can go for surgical management like optic nerve sheath fenestration surgeries, LP shunt, VP shunt, then venous stents we can keep in case of stenosis. And if the weight is like obese class 2 and all, we can go for bariatric surgery also.
How frequently would you like to ask the patient come to you?
Sorry, sir.
How frequently would you like your patient to come to you? How frequently would you like to follow up this patient? Patient is a young child.
Okay.
Yeah, you have to be careful about this particular case.
Yes.
Okay. Yes. You have to follow up frequently. And there is one thing called as fulminant intracranial IAH. There is a variant. That is the latest variant. And it will take away vision within a period of 1 week to 10 days. I have seen patients who lost vision completely up to no PL. Okay. So that's why never take it easy. always ask the patient to come to follow up. Maybe in the evening time after the school hours, he can come and just show up to you, and you can just do the vision assessment and clinical assessment.
Vision and you must record visual fields. See,
Yes,
the progression of visual fields is alarming.
yes,
It indicates that the disease is progressing, so you have to resort to surgical management like optic nerve sheath reconstruction.
Yes.
A question to Dr. Ravikiran, sir.
yes, sir.
How do we differentiate between this fulminant case and the benign case?
No, sir. The rapid progression of visual loss is a hallmark of
So it
fulminant.
is only, we'll know it only on follow-up.
Yes, yes,
Are there any
exactly.
specific signs that we need to look for?
No, sir. The short onset, short period of onset, and rapid progression of visual loss, and severe headache, and the all the other features of IIH, what we see.
Sometimes if we have that severe rapid progression, we tend to think towards AON.
Yes, yes,
So
certainly.
how do you
This
differentiate?
risk of AON is also there in
Ah,
IIH, yes.
yes, yes.
So how to
See,
differentiate between the two?
if we can do the fundus fluorescent angiography, that will tell the answer.
Right.
Okay, so these are the cases which need a FFA, or even the new modality like OCT angiography.
OCT
So,
angio also
yes,
we can.
yes, yes. But FFA
So
will give you the function and the permeability, the hyperpermeability, and the classic presentation like a pool of vertical pool in front of the optic disc in case of papilledema, uh, whereas hyper fluorescence in the case of optic neuritis.
AON, yeah.
In AIO, fields are also different, sir. AIO.
Yes, yes,
Yeah,
yes,
fields also
yes, sir.
different, yes.
We get those altitudinal defects.
Yes.
Altitudinal field is most from this.
Anything else, Tarak sir?
So, to cover the
Protein, sir.
IIH, the management should aim to relieve the symptoms, particularly headache, and preserve vision by preventing damage to the.
Yes, even repeated lumbar punctures also are sometimes advised. Suppose the patient is a pregnant lady or anybody who have the contraindication for topiramate as well as carbonic anhydrous inhibitors, you can as well resort to repeated lumbar puncture. Therapeutic lumbar puncture uh, also can be done.
Nowadays, they are advising shunts instead of
Shunt.
doing repeated LPs.
Yes.
Right. Thank you
No,
very
but
much,
in
sir.
a pregnant lady, you cannot do a LP or a VP shunt also. So that's why via media you can as well practice frequent LP also. Thank you, Rajesh.
Thank you very much. I
Yeah.
should congratulate Dr. Srinavya and Dr. Akansha. And I really thank Dr. Ravikiran Potluri and Dr. Rajan Prasad. Really, you have gone very deep into the subject about both the cases. Thank you very much for your very active participation, and not to forget about the Dr. Tarkeshwar and Dr. Kailan Razu. And Dr. Bishwajit and Dr. Jamima, thank you very much for mentoring your students very well. And once again, I congratulate Dr. Akanksha and Dr. Srinavya, and let us conclude this short cases webinar, which turned out to be a very long case webinar, not a short case. The discussion went on to almost an hour, 40 minutes. That's a long case discussion, not a short case discussion. Still, I'm very happy because these are the type of the questions that will be put forward to all the postgraduates whenever you have the same case in your exam. So Dr. Rajan Prasad and Dr. Ravi Kiran, they have extensively touched all the questions that are possible in these two cases. Thank you very much again. and good night. Let us meet again.
Sir,
Yeah,
send small request.
yes, yes.
You provide online certificate to the presentators.
Okay, we'll definitely we'll discuss in our executive, and then we'll definitely, since we have the list of all these candidates, I'm also thinking about,
Presentator with the examiner names.
yes, yes. We also have a proposal of selecting the best possible best presenter to give them a prize for that also.
Nice.
So we that is all in the pipeline. Once we finish
Okay,
the one session, we'll announce a prize for the best presenter. Right?
Thank you,
Anything
sir.
else? So, okay, then. Thank you very much. Thank you. I thank all the President of Ophthalmic
Thank you, sir.
Society for giving us this opportunity to conduct this excellent program, which is very useful for the postgraduates of the state. Thank you very much.
Thank you, sir.
Thank
all
you,
of
Thank you,
you.
sir. Good night, sir.
Nice.